Cancer Council WA acknowledges the traditional owners of country throughout Western Australia. This recording was captured on Whadjuk Noongar country. We recognise the unique connection that Aboriginal people have to land, waters, sky and community, and we recognise elders past, present and emerging.
Thank you for joining me for another episode of Keeping Up with the Pace. My name's Tim. My guest today is Dr. David Blythe, who is the State Medical Lead for Donate Life. Thank you very much for joining us today, David.
Pleasure to be with you, Tim.
So, David, firstly, simply, what is organ and tissue donation?
So, organ and tissue donation is the process whereby deceased persons can choose to give what we call the gift of life to people in need of medical aid in the form of some sort of transplant. These are people often with life-threatening diseases who are in need of a kidney or a lung or a liver because they've got kidney or liver or heart or lung disease that is no longer treatable and they're facing death unless they get a replacement organ. It may also be not necessarily a life-saving transplant. So I'm talking now about things like corneal transplants for people with visual problems who have no other options left to save their vision, or people with musculoskeletal problems who can benefit from the use of bone or musculoskeletal tissue from deceased persons to preserve their well-being if they've got serious orthopedic problems such as a cancer which needs to be removed and a joint or a bone needs to be reconstructed. So the gift of life is the choice to make use of organs or tissues after you've died to benefit people who are in desperate need of life-saving or life-changing therapies.
And I understand, David, unfortunately, donation can only proceed in very exact circumstances. So what are some of those? What are some of those considerations?
So yes, not everybody can be an organ donor or a tissue donor. In fact, it's quite a rare thing. There are roughly 190,000 deaths in Australia per year, and about half of those people die at home. You need to die in hospital in general to become an organ or tissue donor. So about 90,000, 80,000, 90,000 people die at home, in hospital, But even of those people who die in hospital, only a very small proportion, about 2%, actually die in the circumstances which allow organ or tissue donation to proceed, which is generally death in an intensive care unit, sometimes in an emergency department, but most often in an intensive care unit. So that leaves us about 1,600 potential organ donors. We approach nearly all of those from Donate Life, and about 50% of people consent. So that gets the numbers of potential organ donors down to about 700. For various logistical reasons, we find something in the medical history, for an example, which means that organ donation can't proceed. That gets us down to about 500 people in an average year over the last few years can donate organs in Australia. In Western Australia, we're about 10% of the population. So in Western Australia last year, we had 60 organ donors. So it's a very, very small number of people. And the circumstances are that you have to generally die in a hospital and your family has to provide consent to indicate that they think that this is something you would have wanted at the end of your life. And if the family provide consent and the circumstances are suitable, then we can talk to the family about which organs we might retrieve for the purposes of transplantation into people in desperate need.
And are all of these transplants, are they occurring at North Metro Charlie Gardner Hospital?
No, the transplants occur in several sites. The transplants occur in the big tertiary hospitals. So Charles Gardner, Fiona Stanley and Royal Perth are all involved in transplantation procedures. Retrieval of organs from deceased patients can happen at any of the metropolitan hospitals. It's much more difficult logistically at the regional hospitals, but that's something we're working on at the moment.
Yeah, absolutely. So people in outlying wards that will die and are palliative,
Mhm.
is there the opportunity for them to be then transferred into ICU for the purpose of retrieval?
Well, we generally wouldn't do a transfer of a patient who's in a palliative mode of treatment simply for the purposes of retrieval. What we can offer is the option of tissue donation is very possible for patients who are suffering at the end of their life and are in that palliative mode. Some patients may be in a palliative mode but be in an intensive care unit. So I'm thinking particularly of people with heart or lung disease. They may have decided with their family and their doctors that ongoing intensive treatment is no longer for them. And those people can sometimes donate certain organs or tissues. So it's possible for patients in a palliative situation, and it is possible for patients who are not in intensive care. But most patients who donate are generally in an intensive care unit.
Most of my audience, David, are working in palliative care or familiar with this sector.
Yes.
Is there anything that can be stated in advanced care planning documents that might strengthen, someone proceeding with a donation or retrieval?
Yes, there is. As your audience would know very well, an advanced planning document is something that is very much tailor-made according to the patient's specific circumstances, and they can express their wishes about what treatments they want, what treatments they don't want, how they want their end of life to proceed, and that can include a discussion about organ donation if that's something that they think is right for them. So certainly it can be included in discussions about end of life which is suitable for a particular patient, and it can certainly be included in an advanced care planning document.
I think the listeners will be quite shocked by what the actual donation rates are, David.
Yes.
What do you think, are some of the barriers to it? I mean, you mentioned families who then have to provide explicit consent as they're bereaved, but what else might be factors in people not being able to proceed with the donation?
Well, I think the biggest barrier to donation is really public awareness. Again, as this audience would know very well, death is sometimes a bit of a taboo subject and isn't often discussed. End-of-life care plans are sometimes not discussed, and it's left up to a family, particularly in intensive care, to make decisions on behalf of a person who may not be any longer capable of making their own decisions. So we think the biggest barrier to donation is getting people to talk about death and what is right for them. And one of our very clear purposes in Donate Life is to make sure that not necessarily that donation proceeds. That's a choice. One of our very important sort of mantras is that the decision about donation should be informed and should be planned and should be discussed. And it may be a yes or it may be a no. And both of those answers are perfectly good as long as it's been discussed and planned with the patient. So we think patient awareness and family awareness and discussion about donation is something that is still not as prevalent in our society as we would like to see. We would like to think that everybody makes a decision about donation while they've got time to talk with their family, their medical staff, their representatives of their faith or whatever support people those people, need to inform that decision. And the right decision is the right decision for that person. The right decision may not be donation, but if a person has thought about it and decided, yes, it's for me, then that's good. And if they thought, no, that's not for me, that's also good because it's the right choice for the patient. So I think the biggest barrier is that lack of discussion. But there are other barriers. There's a barrier around, WA is very difficult geographically. We are a very long way from anywhere, including the rest of Australia. So there are logistical barriers. If you're in Melbourne or Sydney and you're waiting for a transplant, a person sitting in Melbourne waiting for a transplant, it's not a long way to Sydney if an organ needs to be transported. But it is a very long way from Western Australia if you're in Brisbane waiting for a heart transplant and a suitable donor comes up in Perth. So distance is a barrier. Public awareness is a barrier. So I think those are the two major problems, but particularly public awareness and discussion around organ donation.
You just mentioned something there that particularly piqued my ears there, David. You mentioned someone potentially in Queensland waiting for a heart from WA or vice versa.
Mm-hmm.
Can you walk me through that process? How does it get from point A to point B when it's so vast?
Okay, so let's take that example. A patient in WA has decided to donate and he's got a heart suitable. That the team, the Donate Life team and the surgeons will say, listen, we've got, Mrs. Jones here and she's deceased. She's had a terrible injury or whatever. And her heart is, these are the blood tests and this is the immunology and this is the tissue typing and all that sort of technical stuff. And it turns out that the only person in the country that it's suitable for is in Brisbane. So the process of organ donation means, obviously, once the person's deceased and declared dead, they go to theatre and that heart will be retrieved from the dead body. And it then gets transported to Brisbane by air. And organs can survive a variable time.
Mm-hmm.
Kidneys are probably the best. Liver's probably the most fragile. But hearts and lungs are somewhere in between. So the organ will get transported. It's preserved in a ice box. Basically, it gets cooled down, which prevents further metabolic activity of the heart, and it gets on a flight. If we can coordinate the flight with commercial airways, we do that. And it flies to Brisbane, and then the surgeons at the other end will be waiting for it and will transplant it into the Brisbane recipient. So it's quite a logistical exercise because we have to coordinate the time of the retrieval procedure, and then it has to go straight to the airport, straight onto a flight, straight off the flight to the hospital, and straight into theatre. And you've got a window of, depending on the organ, up to 24 hours to get the transplanting organ from A to B, which is enough time to get to Brisbane if you're organised.
And does the person that you've retrieved the heart from in this circumstance, is their family notified that it has been donated to someone?
Yes. So we don't retrieve any organs in Australia unless there's a specific donor, so we know where it's going. So sometimes we have the situation where a person, for instance, might have a very rare blood group and there's no suitable recipient. So we wouldn't retrieve an organ unless it had a destination, if you like. So we will know that, if we have a grieving family and they've said, yeah, well, you can retrieve heart, liver, lungs or whatever, we will tell them that we're only going to retrieve heart and liver because, Dad's blood group meant that he's not suitable. There's no recipients waiting for his particular type of, of lung transplant, for instance. So they will know, the family will know beforehand which organs are going to be retrieved and used. When the organs have been retrieved from the deceased person, then we will let the family know that the surgery has been completed. And then when the transplanting surgery, when the lungs and the heart or whatever have gone into the recipients, again, we'll let the family know that, your dad's liver went to a young man in Brisbane who was suffering from, terrible liver failure. And so far he's doing well. And then we continue to follow up with the family of the donor. And we will call them and let them know on a periodic basis that, it's now 3 months out. We know that, your dad's liver is doing well in the young fellow it was transplanted to in Brisbane. So, and they can have that follow-up for as long as they feel it's helpful and supportive.
That must be such a cool feeling.
It is a cool feeling.
Mm.
It is a cool feeling because we find that information about the recipient is really important to a donor family. It makes them feel like a tragedy has a positive outcome. The death hasn't got a purpose, but it's got a meaning. It's got a meaning in that, if your dad crashed his car into a tree, or whatever tragedy happened, then it's not as senseless as it might otherwise be. Dad had a terrible accident, but we know that his liver went to a young fellow in Brisbane, and his lungs went to 2 different people in New South Wales, or whatever. It gives some sense of positive outcome out of what is invariably a disastrous time for a family.
Can you talk about who's a part of your team, David?
So we have a relatively small team. There's myself and about half a dozen other doctors in the various hospitals, particularly the tertiary hospitals. And we have a staff of highly trained specialist nurses. There's about 15 of them or something. And we have some administrative support staff. The doctors are all either intensive care specialists or physicians involved in transplant. The nursing staff are nearly all from an intensive care background, because such a lot of our work is in the intensive care unit. It's very helpful for a nurse to understand and be able to operate in that environment. So the nursing staff are all highly trained. Some of them are based at our central office, and some of them are designated to a particular hospital. And then, as I say, we have some support staff, administrative staff as well. All of those people are the vital members of our small team and coordinate all of the work that the agency does. I probably do the least of anybody.
So what does a good death look like then to you?
That's a very good question. A good death to me is probably most importantly one in which the patient's not A, in any pain, or B, in any distress or anxiety. I think those are the things I'd put first. A very close second, I think, is that a good death is one where you're supported by your family or your carer or whoever is important in your life, that they are present and that the circumstances are such that you can be with them or they can be with you, depending on how the patient is. Some patients die when they're unconscious, and many of our patients in intensive care will be unconscious at the time of their death. But I think it's very important that family and support people are present. To me, those are the first 2 things. But particularly in regards to donation, I think, well, maybe not just in regards to donation, I think that a good death is one in which the circumstances of one's death are aligned with what one's own values and wishes are for how that death might happen. Clearly, some people die unexpectedly. The unfortunate man who drives into a tree on a dark country road, that's not the death he would have planned for himself. But I think if the circumstances allow, it's a good death looks like one in which, this is how I was thinking the end might look for me. I'm at home with my family, and the dog's at the bottom of the bed, and I'm not in any pain, and sooner or later I'm just going to go to sleep and not wake up. And organ donation can be part of that discussion. Organ donation, or what happens around the circumstances of one's death. I think if a person can die in a way that is planned and all options have been considered, do I die at home? Do I die in hospital? Do I die with a big family contingent, or do I die with just my wife? Do I die, on a special day? Do I check out at a time and place that suits me? What do I want to happen with my body? Do I want to be cremated? Do I want to be buried? Do I want my ashes scattered at the beach? Do I want my ashes scattered in the garden? All of those things are very important if one can plan it, if one has the good fortune to be able to plan one's death. And as I say, I think planning around, do I want my ashes to be scattered at the beach, is important. And do I want to consider organ donation is also important. So that's what a good death looks to me like. It's pain-free, it's anxiety-free. My family and friends are there, whoever I want, and that it's the death that I planned and would have wished for.
People with life-limiting illnesses that choose to VAD, are they eligible to donate?
Yes, they are. Yes, that's been happening internationally for about a decade, and it's been happening in Australia since 2023. It's happened in New South Wales, in Victoria, and in Queensland. We've been working on developing a process for allowing people undergoing a VAD end-of-life pathway to be able to also organ donate if that's their wish. It hasn't happened yet for organ donation in Western Australia, but it has happened for a small number of people who wanted to donate tissues like eye tissue after a VAD end-of-life choice. So yes, it can happen. It's a fairly recent development in WA. So yes, it's possible.
What do people working in health settings, what do they need to know more about organ and tissue donation?
Well, I think people need to know that it's available. It's not available just to the restricted group of people who sometimes, one of the big mistakes we sometimes make, I think, in the community and in healthcare is that we think only a 40-year-old athlete can be an organ donor. That's not the case. People in their 60s and 70s and up to about 80 and maybe even beyond can donate organs and tissues. Not every 70-year-old has multiple medical problems. Lots of them do. But it's not the case that age is as strict a criteria as it maybe was when transplantation was in its infancy 30, 40 years ago. So the age criteria are sometimes surprising, and I think we need to educate medical staff and the community on you don't have to be a fit, 40-year-old athlete to be an organ donor. You can be much more elderly than that, and you can have medical problems. Just because you've got heart problems doesn't mean you can't become a kidney donor. So yeah, there are some myths around, and medical staff and the community might be a little bit surprised by how much more flexible organ donation is than it was, when Christian Barnard did the first heart transplant in the 1960s. We've come a long way since then. So yeah, more education for medical staff and for the community about the logistics and the practice of organ donation is always going to be useful.
Is the donation registry, is that standardised across jurisdictions?
The donor registry is a national facility. How you get onto the donor register varies slightly from one jurisdiction to another. Another myth about organ donation is that you cannot register via your driving license. That went out over 10 years ago. And the only jurisdiction in which that was not part of the process when we got rid of it was South Australia. So South Australia, you can still register via your driving license. So registration rates in South Australia are much higher than the rest of the country. Only about 36% of people across Australia are registered, and it's about 70% of people in South Australia, which kept the driving licence option, are registered. The good news on that front is that recently we collaborated with the Department of Transport so that those of your listeners who've recently received their licence renewal papers or their driver renewal papers will have, I hope they will have noticed that there's now a QR code on the renewal forms, which is a direct link to the Donate Life website and the ability to register. It's not as easy as it used to be, which was just ticking a box, but there's now a QR code, and it takes about 2 minutes to register. So if any of your listeners feel like they would like to register, The Donate Life website has a lot of information, and as I say, you can either register there, you can register through Medibank, or you can register when your driver's license application comes up.
How do you manage expectations?
That's another good question. So I think when talking to donor families, one of our main jobs is the provision of information. And as I say, information is a little bit lacking out there. It's an issue that doesn't get talked about a lot. There are some myths and misunderstandings around organ donation. So I think the first part of managing people's expectations is to provide them with the correct information. So our specialist nurses spend often many hours talking to families and saying, this is the information we'd like you to consider, and these are the these are the things you may or may not understand about organ donation, in order for them to make that right choice.
Mm-hmm.
And as I say, the right choice may be no, it may be yes, but it's very important that people have information in order to even consider organ donation at what is invariably a very traumatic time for a family. So that's the first part of managing expectations. The second part is, if a family decides that organ donation is for them, it's about a more detailed explanation of, okay, well, what is possible? What organs can be donated? How does that look in terms of, my mother's passing? Will the body, be changed afterwards? Can I see the body afterwards? What happens to the organs? Do they go to Western Australia? Do they go interstate? Do they go to New Zealand? Do they go, what happens to them? How much information will we get about the recipient? How much information will we get about their progress? What support is available to us as a family? So we can provide answers to all of those questions while a family is making its decision. So managing expectations, I think, is about provision of information about organ donation in general, and provision of information about, if it's for our family and for, my dad at the end of his days, then what can I expect from the process, and what support will I have after this is done if we decide to go down that track. So managing expectations is a big part of what we do, because people sometimes don't have a lot of information, and people sometimes have things that they might wish to happen that we can't fulfill. People may think that, I really want my dad to be a heart donor, but if his heart isn't suitable, then we have to say, well, listen, there isn't anybody in Australia that is a good match for your dad's heart. But, it's really good that we can take the liver and the kidneys or whatever it may be, for people who are in desperate need. So provision of information in a detailed sense, I think, is the second part of managing expectations about what does it mean for me, not just what does it mean for the community, but what does it mean for me and my family.
Yeah. Do you have a particular case that sticks with you, David, that you can talk about?
This was your most difficult question. For reasons of confidentiality, of course, I can't go into very much detail.
Yes.
But there are certain cases that stick in my mind. There was a case of a young lady who had a young, healthy lady in her 20s, who she had a dreadful accident. She was competing in a horse riding tournament and came off, and terrible head injury, and ended up on a life support machine with an unsurvivable catastrophic brain injury. And somewhat unusually, she had discussed organ donation with her family. And she'd made it very clear that that was something she was fully supportive of. Fully supportive. And so when it came time to talk about the fact that, this injury she'd had to her brain was unsurvivable and her brain was dead. She was what we call brain dead. She'd had the tests and there was no longer any blood flow to her brain. So she was never going to recover and she was just being kept alive by the machines. Part of that discussion about, how do we manage turning off the life support machine, part of that discussion is obviously, have you ever considered organ donation? And for a 20-year-old or whatever she was in her early 20s, I think, for that person to have discussed death with her family, as I say, was really quite unusual, but she had. And she went on to become an organ donor for multiple people right across Australia. And we see her father from time to time. He's involved in our Donate Life publicity raising activities. And he comes into the office now and again. He'll bring us some morning tea or something. And I know that he's found an enormous sense of meaning out of his daughter's death. Because he tells us that. He said one of his ways of coping with a devastating personal tragedy is to think, most importantly, that although her death was unplanned, it was very important to this young lady that her death was meaningful in the sense of providing a benefit to people in need of a transplant. It wasn't the death she expected, but in some senses, at least some of it went the way she wanted. She wanted to be an organ donor. And although that's only a small consolation, I think that family felt it was a bit of light in an otherwise very dark place.
Yeah. What a selfless act. And seemingly gave a lot of closure and reassurance to the family.
And I can't imagine what it's like to feel like that, what that family have experienced. But they tell me. So yeah, it's rewarding.
Thank you for sharing that, David. I was going to open up the floor. If there's anything else you want to add, anything you want to talk about, some of Donate Life's activities.
The only thing I would say to all the listeners is that, as I say, I'm not here to advocate for organ donation. I'm not here to advocate for it's the right thing to do. But I do want to say very strongly that it's really important to talk about it with your family, because the most important thing is that what happens at the end of life is what the patient wants. And organ donation, we think, should be part of that discussion. It may not be right for everybody, but it's really hard for a family to make that decision at a time when they're going through intense personal loss and tragedy. So talk about it now. Talk about it with your family. Talk about it with your friends. Make it part of your everyday conversation. We spend a lot of time, making a decision about which fridge to buy or which car to buy. Maybe we should spend a bit of time talking about what happens when mum finally gets to the end of her tether. So that's my only message. Talk about it, because public awareness is one of our biggest barriers.
Dr. David Blythe, thank you so much for your time.
My pleasure.
Thank you for joining us for another episode of Keeping Up with the Pace. Anything referenced in today's episode will be captured down in the show notes. You can follow us on social media platforms LinkedIn and Facebook, or you can head over to our website, PaSCE.com, for any education or training needs that you have. Catch you in the next episode. Bye.